Hello and welcome. You are watching Lockdown TV. This is the online pop-up news and discussion program from unheard.com. Last week, we had on the show a Swedish epidemiologist called Professor Johan Giesecke, who gave quite an extraordinary interview to us where he basically criticized the UK response to coronavirus and laid out his arguments for why lockdown measures are not actually the right answer. One of the studies that he talked about was the now famous Imperial College paper overseen by Professor Neil Ferguson, and I am delighted that he is now joining us to give his input into this debate so that we can get a better understanding. Are you there, Neil?
Yes, I'm here. Good afternoon.
Good afternoon, and thank you very, very much for making the time. It makes a real difference for all of those people who are trying to understand the details in a bit more than you get in a 3-minute BBC interview. I should say also thank you for all of the work you're doing. I mean, it must be unbelievably stressful during a time like this to be trying to work out what's going on with patchy information and everyone throwing arrows at you from all directions. So thank you for that. Let's just get straight into what I just began starting with, which is what Professor Giesecke was telling us last week. So he essentially is of the view that the paper you guys produced on March the 16th was wildly over-pessimistic, that the 510,000 mortality figure would never have happened anyway, and that the 250,000 dead figure for a mitigated approach was also overly pessimistic. So he was quite critical of your paper, and I just wanted to give you the chance to respond directly. What do you make of what he was saying, and what do you make of the Swedish policy more generally?
Yeah, well, maybe I'll talk about the Swedish policy. I mean, I know Johan quite well. We disagree, and I would say the majority of epidemiologists would support my position. Sweden has taken its own course. I mean, the epidemic in Sweden is interesting in the sense that they clearly have slowed spread with voluntary social distancing. And we think that has actually brought this key number, the reproduction number, which probably starts at about 3, down to 1.5, 1.4 there in Sweden. That slowed the trajectory, but Sweden is still seeing day on day, well, with a lot of weekend effects, day on day increases in deaths and cases. And so the real issue is they're at a point now where their per capita mortality in Stockholm is approaching New York. And we saw what happened in New York. I think Sweden has had more time to ramp up intensive cares provision. But I think we're going to see their deaths slowly continue, day by day increase, the daily deaths day by day increase. And it is clearly a policy decision for the Swedish government whether they wish to tolerate that, but I don't think it's a decision most other countries have made, clearly. In terms of there's some interesting studies coming out at the moment in terms of the true proportion of population infected. Actually, in Stockholm, there was a study of blood donors suggesting maybe 10% of the population of Stockholm might have been infected. That's actually broadly in line with what we would have estimated, given their quite high per capita mortality in Stockholm. So taking our sort of estimates of fatality rates, and I should say you really have to adjust those by age. There's no single number for a population. We know it affects different age groups very differently. So adjusting for the demography of Stockholm, what's happening there is broadly in line with what we expected.
So I think the latest number they came up with, they put out a study that suggested 30% of Stockholmers would have had the disease by May the 1st. Then they retracted that, and they've now said they think 26% of people will have had it by May the 1st.
Well, that's quite plausible. I mean, there was a serological study published yesterday for New York, which suggested New York City has a 21% of the population has been infected. That gives... Well, it's hard to precisely translate that into an infection fatality ratio because we don't know quite how sensitive the assay used for measuring seroprevalence was. when it detects infection. We don't know how representative people in supermarkets in New York are. And we also don't know whether the final death count is really in. I mean, it's likely to still go up retrospectively. But nevertheless, it's compatible with, as Governor Cuomo said, between about a 0.6 and 0.8% infection fatality rate in New York State.
Would you expect that to come down or up over time? Because some people have been saying that, if the first 20% had that fatality rate, as it were, the next 20% would contain fewer vulnerable people and there'd be greater immunity.
There's not much evidence of that. In fact, probably the vulnerable people, the older age groups, have lower contacts than the average population, so it takes transmission longer to get to them.
Right.
You also have to be very careful to correct for demography. I mean, New York City is a much younger population than the United States as a whole, so we would expect a slightly lower infection fatality rate in that population, a bit like London as well. London is much younger as a population than the UK as a whole. And so there are a lot of subtleties. I think overall, though, I'm comfortable that our estimates were certainly in the right range. And when we published infection fatality ratios for China, we estimated, for China as a whole, about 0.66%, with quite a lot of uncertainty around that. In older populations, that goes up because the disease affects older people much worse. And then in younger populations, such as sub-Saharan Africa, it goes down.
So, what do you now believe the infection fatality rate to be, or what do you believe the?
Well, that's why I say there's not a single number. It depends. You have to be very carefully look at what population you're looking at infection is. There is not. I mean, it will depend on.
For the UK population, what would you expect to be relevant?
I mean, we'll clarify that much more once we have more serology data in the next few weeks, particularly representative surveys. I suspect around the kind of 0.8%, 0.9% level, so quite similar to the sort of numbers, certainly well within the confidence range of the numbers we had previously used.
So the New York study you just mentioned, so if 21% of New Yorkers have had it, that would then be 1.76 million people, and they've had 11,000 odd deaths. So it's would that not imply?
It's about you get the point estimate of about 0.65% when I looked at the calculation. So you just have to bear in mind that
that's wrong. That's as it were optimistic. You think it's about 50% greater than that then? Or
well, no, it's in line with what we would expect for New York. New York's a young population. If you go out to other more rural areas of America, in much older populations, you expect a larger number. That's why I say people should stop obsessing about a single number for IFR. It depends on the population you look at. Yeah. Our UK estimate, I say 0.8, 0.9%, in London probably is going to be about 0.6% for exactly that same reason.
Right.
Stockholm is slightly older, actually, so probably slightly higher there.
So if we put the sort of infection fatality rate question to one side, I guess the other aspect of the your March model that Professor Gieske was querying was essentially the difference between what the outcome would get with a so-called mitigated strategy versus the outcome with a suppression strategy, because your model gave a number of potentially 250,000 deaths if we did a mitigated strategy, which seems similar to roughly what they're doing in Sweden, whilst it might be reduced to sort of 20,000 range if we do a full suppression. Isn't this the evidence of what we see in Sweden, where it may be higher than its neighbours in Scandinavia, but it's certainly not 12 times higher than we've seen in the UK. In fact, it's lower than what we've seen so far in the UK in terms of deaths per capita. Isn't that evidence that the results with the mitigated strategy might have been better than you forecast?
I mean, to be clear, Sweden are not adopting a mitigation strategy, and they're denying they are. They have much more social distancing in place than we modelled for a mitigation strategy. The point of a mitigation strategy is you go through the epidemic, you get herd immunity, you lift measures quite quickly. We estimate Sweden, as I said before, have got more than half the reproduction number. So that's a lot more than mitigation. It means that they will eventually see the epidemic come down if they keep the current measures in place, but they won't have reached herd immunity. And indeed, their own estimates say they're not, and they state themselves that's not their goal. What they have is a sort of semi-suppression strategy, which is a lot more intensive than we modelled as a mitigation, where there we were basically just talking about modelling individual case isolation, household quarantine, and then the elderly population, being shielded. I mean, they have large-scale social distancing, just not as intense as other European countries. So I think it's kind of a false comparison, certainly with the modelling paper we did. They're not in a mitigation scenario.
Yeah, just to stick on that for one sec, one of the assumptions in your model was that in a mitigation strategy, only 50% of people would observe self-quarantining if they were displaying symptoms.
About 70%, yeah. We made deliberately quite conservative assumptions.
Do you think now, having seen how people have both were reacting in the time leading up to the sort of legal lockdown, the professor, is it Carl Hennigan in Oxford, who points to some evidence that the peak was actually before the lockdown started, which suggests that people were really voluntarily being quite kind of assiduous about their social distancing, even before being legally told to do so. Do you think, having seen what's happened, actually more of that mitigation approach might have had more dramatic impact?
Well, I move away from talking about mitigation versus suppression. I mean, I think there's an valid discussion to say, how do populations respond to advice, let's say, or strong indicative guidance that they should do this versus compulsion. But to be clear, I mean, the government on 16th of March, I mean, the Prime Minister in this country recommended measures which were akin to a voluntary lockdown, and that was made much more formal on the 23rd of March. So it wasn't like we were following a mitigation strategy. The aim, it was to reduce the reproduction number below 1, to reverse transmission. Our own estimates is that probably infection rates peaked, somewhere in that week, somewhere between the 16th of March and the end of March. It's very difficult to be more precise than that. So the policy goal, though, was to curtail transmission. And we acted, in some sense, just in time. I mean, London hospitals and hospitals actually in the Midlands were extremely stressed by the time the epidemic, in terms of the hospital epidemic, 3 weeks later peaked. We now see, as we hope to see, numbers in hospitals go down.
Mm-hmm. So have you been surprised by how careful and sort of content to be locked down the public has been? I mean, you've had to include a lot of assumptions in those models.
So yes, I mean, generally the population adherence with these measures is higher than we had assumed, and we had to assume numbers. There's no prior evidence on these sort of measures. So we think we've brought transmission down. There's been effectively an 80 to 90% reduction in contacts between people in different households. We brought the reproduction number down to, somewhere in the region 0.6, 0.7, which has reversed transmission. That means the epidemic is in decline now. The challenge going forward, though, is that it doesn't give us a lot of leeway to relax without other interventions. I mean, down at 0.6, if we go above 1 again for the reproduction number, we'll get increasing case numbers. And we're at maybe 0.6, 0.7 now. So we've got that little bit of wiggle room. So if we want to move away from lockdown, reopen schools, reopen workplaces, let people go shopping again, we have to substitute other measures. So I would move away from looking at Sweden. I mean, I think Sweden have made their decisions, and we will see over time whether those are the right ones. I think the country we should be looking at, though, is South Korea, which is a much better model and has a way lower mortality rate per capita than any of the countries we've been discussing so far.
Aren't they? I mean, what Giesecke was suggesting is that countries like South Korea that have been very successful in suppressing it are essentially only delaying the pain in some way, and that, when it all comes out in the wash, they'll get similar kind of mortality to other countries. And he says the same of Denmark.
I think that's an unnecessarily pessimistic view, shall I say. I mean, he's basically saying we should just allow all these old people to die because he doesn't believe we can maintain measures in place. I think if you talk to people in Korea and people in the public health department, they think they have a sustainable strategy. They have society not operating as normal. There will have to be social distancing until we have a vaccine. It won't be normal society, but they have been remarkably effective at basically tracking chains of transmission down and isolating people who are infected. And the real benefit of those policies is that if you drive transmission down to the very low levels they now have in Korea, then it's not that disruptive or resource intensive. You only have a few hundred cases a week. Yes, that results in a few thousand people a week requiring isolation, but it's very different from having a large chunk of your population in isolation.
I think, I want to make sure I'm not mischaracterizing what he was saying, but the policy he was offering was neither mitigation nor suppression in those terms, it looked like. What he was suggesting is that we should have isolated and shielded the old and vulnerable better from the beginning. And he was very frank about the fact that he thinks Sweden has failed to do that well.
Every country has failed to do that. UK has failed to do that. So it's all very well saying we should isolate and shield the old and vulnerable. They tend to be either in care homes or the most socioeconomically disadvantaged groups. And no country has shown an ability to be able to do it. So it's kind of wishful thinking, really.
But isn't that where, it just seems, intuitively, it feels, I think, to a lot of people that here we are putting all this energy on keeping young and healthy people at home. Meanwhile, the only people who are not kept safely at home are the key workers who are actually coming in contact with vulnerable people. So, those people who
I completely agree. We need to get on top of what's called infection control in both care homes and hospitals. It's been a problem across the world. It's not unique to this country. And going forward, we need to do better on it, without a doubt. What we've seen in this epidemic in many countries, but the UK data I know the best, is about 2/3 to 70% of deaths are occurring in hospitals, but about 1/3 of them are occurring in the community. And that latter number may go up over time. You'll be aware when people look at spikes of excess deaths, all-cause mortality, those are really quite large. It can be twice as much as the coronavirus deaths. And so that, in my view, is one of the reasons why we want to get case numbers as low as possible. Because there are two sort of...
Keeping case numbers low as possible across the entire population is the only way of effectively shielding the old and vulnerable.
Well, I think there's two different issues. There's where we are now, and I completely agree. Lockdown is not sustainable long term. We have to move to a different strategy. But if we can move case numbers down low enough, then I think we can look to the Korean model of how we sustain control of transmission long term. That has many benefits. It's not certain we can achieve it, but I think it's something we certainly need to try, given the economic and social and other costs of lockdown. Because by keeping case numbers low, as compared with the Swedish model, where they have half their hospital patients are COVID patients, you treat other conditions better. Some of the excess deaths we're seeing at the moment, all-cause excess mortality, is probably down to people not being able to access healthcare for other conditions. So if we can get case numbers low, we can start treating all those other conditions again, you resume elective surgery, and we have a much lesser effect on the economy and society as a whole. But you need to start from a position of relatively low case numbers to implement that sort of policy.
On that last point that you just mentioned, the danger that people aren't receiving proper treatment for non-COVID related health conditions. There was one oncology professor who came out and suggested that he thinks that he's going to see more deaths over the long term from cancer treatments that haven't been properly given than he's going to see from COVID. Was that in your model at all? Did you make?
No, we didn't. We didn't allow for. There were two things. That's why I can think we've been quite conservative. Two things we didn't allow for. One was if we had massively exceeded healthcare capacity, the mortality rate among coronavirus patients would have been much higher because nobody would have been, getting ventilation. The second was absolutely, if you stress health systems to that degree, you cannot treat people with other conditions, and therefore you have a multiplier on mortality as well. And I'm sure part of what we see when we look at these enormous spikes in excess deaths in heavily affected countries is not just undetected coronavirus deaths, it's people dying of other conditions which otherwise might have been treated.
So in a sense, that makes it more of a sort of urgent priority to
get case numbers low.
Does that mean that we need to there comes a point where lockdown is not only not viable economically, but it's actually potentially causing more?
I mean, there's an interesting, and I don't know the answer to this question. Lockdown itself has had probably significant, certainly mental health, social, and other impacts, and probably impacts on mortality just from the nature of isolating people. But the thing which has probably had the biggest impact is the enormous surge of demand on the healthcare system, the cancellation of elective surgery, as you say, cancer treatments being delayed, everything else. All of those effects would have been much worse had we not adopted lockdown. We would have seen enormous spikes in mortality in a sustained period of several months of not having healthcare capacity for other types of patient. I think the best way in terms of going forward is to drive case numbers as low as we can. And at that point, we will have the health capacity we need to resume normal service in the health systems. And then it will allow us to relax some of the more socially, economically, and frankly, emotionally disruptive aspects of lockdown. To be emphasized, our modeling suggests, other people's modeling suggests, we cannot go completely back to normal. There will have to be, until we have a vaccine, there will have to be a degree of social distancing in place if we don't expect to see second waves of transmission. But it will look closer to normal.
So, that's the key question, isn't it? And that's where I guess it becomes more of a political question than purely a scientific question is, would people prefer a society which has a sort of long-term anxiety and social distancing and so on in place until an unidentified future point? Or would they, rather say, okay, as long as the healthcare system is not overwhelmed, that will be our measure of releasing or reintroducing restrictions?
Yes, I think I don't want. There are lots of political decisions to be made here, and I don't think I have no greater right to influence those decisions than anybody else. But I do agree with your last point that in terms of the health impacts, never mind deaths, being driven by having a health system which is functioning is a good metric, because then you can treat not just coronavirus patients, hopefully at low numbers, you can treat everybody else who needs healthcare. That was actually the motivation for our paper.
Right.
We were looking at surges in healthcare demand and how do you avoid a health system being overwhelmed. And we got quite close to it being overwhelmed in the UK.
But on that, there are voices in the media and elsewhere who are kind of skeptical about that in some sense, because we hear daily from Matt Hancock that there are thousands of ICU beds available, 3,000 odd more than might normally be available at this time. We've built a 4,000 strong hospital in East London, which is pretty much empty. There are other ones popping up around the country. There hasn't been a single report of a single hospital being overwhelmed, to my knowledge. At
the peak a few weeks ago, there were various single hospitals across London and some other areas which could basically take no one else. But as a nation, as we always predicted, we said, we acted in time to prevent the health system being overwhelmed. And I think that has largely come to pass. I think there have been hotspots where things, and you just need to talk to intensive care physicians in London, where things got pretty close. But yes, we did not see the situation which New York City saw, which was, considerably worse.
In which case, great, the lockdown did its job. We now have built huge additional capacity in the healthcare system. If that's the reason for introducing these measures and the reason behind your paper, surely, that on its own provides a route, a sort of rationale for how you would lift or reintroduce the
Indeed. I don't have a...
From that now, would you agree with that? It's no longer it doesn't seem like that is now what is being considered the mark of success, because evidently we now have enough capacity in the healthcare system. It's not currently being overwhelmed. It seems to have moved to something else.
Yeah, I mean, there's multiple, and I'm a scientist, and as I said, I don't think I have any greater right than anybody else to make political or moral judgments on what countries should do or politicians should do. I know this country and other countries are grappling with what comes next, and there will be a trade-off between the extent to which you relax measures and tolerate a level of transmission and therefore mortality and therefore health system demand versus keep case numbers as low as you can, which probably will require, social distancing longer term. Not at the levels we have today if we have contact tracing in place, but still significant. As a scientist, I kind of feel I can give some insight into what the consequences of certain decisions would be, and indeed into potentially the sort of measures which would be needed to achieve a certain outcome. But really, it's for decision makers to make those decisions.
So do you see in in terms of length of time, are we talking about years here? I mean, how long before we could see life get back to normal?
So, I mean, that is critically dependent on what decisions are made. If you make the decision to suppress transmission indefinitely, then we will still see small amounts of transmission and maybe some build-up of population immunity, though there's a lot of uncertainty about quite how protective immunity is under any scenario. And those measures would have to be in place, and really until we have other means to control the virus, namely either very effective drugs or vaccines or other, basically pharmaceutical interventions. And I don't have any greater insight than anybody else. I mean, it's likely to be a year, in the best case, a year before we have vaccine. It could be considerably longer than that. If you run at a kind of higher level, willing to tolerate a higher level of transmission, then you will have much more in the way of both direct coronavirus deaths and indirect deaths from the health system being stressed. But at some point, it will probably come to an end.
So on that, and that, as you say, that really is kind of a political, or it's a societal decision, isn't it? I mean, those people who say, why can't we just put all our energy in doing a better job of shielding those remaining vulnerable and old people who haven't yet had the disease, and say to under 40s or under however long, whatever the threshold is, off you go, out you go, and go and get it. Basically, we have modelled these, and we are modelling exactly those scenarios. It is in practical terms, you would require a very high level of effective shielding for that to be a viable strategy. Not because the most vulnerable people are also the people who most need care and have most interaction with the health system and are least able to really be truly isolated. You can have a perfectly fit and healthy 85-year-old who's very capable of ordering online and getting stuff in. They're not the people most at risk of death. Most people at risk of death are in care homes or more vulnerable or have other health conditions. And as you said earlier, we just haven't done, and I'm very skeptical we can get to the level of shielding which would make that a viable strategy. In theory, it might be, but until I see a country or even a community do a better job than we've seen so far, I remain skeptical that it's achievable. And if you just achieve, for instance, 80% shielding, 80% reduction in infection risk in those groups, we'd still project you get well over 100,000 deaths later this year through that sort of strategy. So we seem to be in a horrible position, basically, don't we? I mean, you've been modelling these things and looking at previous epidemics for years. You've been giving advice to government. All Western governments have been thinking about these things. We've got one of these pandemics. How have we managed to get in such a position that we basically have no idea how to get out of it?
I mean, I actually think you can turn that question around. I think it's quite remarkable, and China showed the way, that we have basically stopped a highly transmissible respiratory virus in its tracks. I mean, the last virus which had comparable characteristics, which affected the human population, was the 1918 Spanish flu. And whilst I studied this over 10 years ago, some US cities actually did try to control transmission through actually lockdown style measures, and it succeeded for some weeks until then the pressure came to relax those measures, and then they saw substantial second waves. Nevertheless, I mean, those measures still actually had benefit. Those cities which did attempt that had lower mortality than, even with the second wave, than the cities who didn't. But I suppose I never expected to see in the 21st century the world attempt to do this. So I think you can be pessimistic. You can say, how do we get out of this? But we're in a much better situation now than we would have been if we'd in terms of just the overall health impact and mortality, had we done nothing. And I actually have quite a lot of confidence in human ingenuity. I mean, I think I point to the Korean example. I think it won't be normal until we have a vaccine, but it will be something much more akin to normal, and people are adaptable and cope with much more traumatic situations than this around the world. My real concern at the moment is there, and we're doing a lot of work in the centre I head on low and middle income countries who have many fewer, much less in the way of resources, certainly very little ICU capacity, tend to have younger populations as well, but are likely to have higher mortality in the people who do get infected. And how do we advise countries without the same level of economic and technical resources to respond to this? And that's much more of a challenge right now.
Let me, before I finish up, Professor, how do you feel in terms of you're a scientist, you're on these government committees, you're interacting with politicians all the time. Do you think we're sort of...
correct that. I'm not actually interacting with politicians most of the time.
Right.
I'm interacting with people like our government chief scientific advisor, Patrick Vallance, chief medical officer, Chris Whitty, who I don't think would describe themselves as politicians.
It sounds, from the morning's papers, sounds like Dominic Cummings, at least, has attended some of these meetings, and he would be a political figure.
Yeah, I mean, there have been a number of observers at meetings who, I have to say, have not interfered with the business of those meetings at all.
Do you feel that the way the government and other countries as well is dealing with it, are they kind of hiding behind the scientists to some extent? It sounds to me like the decisions ahead are quite clearly society decisions about what level of risk we want to live with and what kind of world we want to live with. Do you feel that you're being sort of held up as the arbiters of these things, and the politicians are ducking the harder questions?
It's a difficult question to answer. I don't think so, particularly in this country. I think there are other much more politicized debates going on. What I worry about more is people who have a particular political agenda or point of view distorting the science to support that point of view. I mean, I've tried to give my judgment to what direction the science points in. There is an open question. Countries will take different decisions on how they go forward. Now, even the countries which have locked down, and there is scientific uncertainty there, and I think we have to appreciate that. I mean, that's why I would not be directly critical of, for instance, Swedish scientists or indeed politicians. I think they've made a decision which will have certain consequences, but it's understandable how they reach those decisions. I think the best thing scientists can do is try to opt for objective advice. And I'm conscious in myself, there's a tendency to become wedded to a position you've taken and find it difficult to revise views in terms of new evidence coming forward. And it's something I'm very conscious of. I would love to find evidence that somehow this virus is much less lethal than we had estimated. I don't think the evidence points in that direction at the moment, but I would be the first one to be happy to be wrong in that case. In terms of the interaction with policymakers, I mean, I haven't seen, in my UK experience, is that we have given insight into how different courses of an action would lead to certain consequences. Estimates of if you did this, then this might happen. If you did this, then this might happen. We have not made politicians' decisions for them. politicians have made the decisions.
Will you be doing another sort of model Mark II to tell us how we can get out of this? Or
it's in progress at the moment, indeed.
To be coming in numbers of days or weeks, or when?
In days, probably.
Great. Okay, well, we look forward to that. Professor Neil Ferguson, thank you very much.
Thank you.
Right, you have been watching Lockdown TV. That was Professor Neil Ferguson of Imperial College, responding to some of Johan Gieseke's criticisms and giving his sense of the lethality of this disease and what we are all going to have to do in the months and possibly even years to come. We will be back next week. Thanks for watching.